First speaker, our keynote address by Dr. Ankur Singh, Clinical Octa Made Easy. Welcome, Dr. Ankur.
Very good morning, all. Thank you, KSOS, for this wonderful opportunity. Thank you, Dr. Anju. I'm going to talk about OCT angiography. So, why OCT angiography? OCT angiography is a nascent, fast, dye-free, non-invasive technique to visualize and assess retinal and choroidal vasculature abnormalities. It provides us with cross-sectional as well as en-face images to detect structural, perfusion, and vascular flow abnormalities. Unlike FFA and ICG that detects blood flow only in the complete retina because it treats the retina as a unit layer, you can detect blood flow with the help of OCT angio in superficial, intermediate, deep retinal capillary plexus as well as choriocapillaries. So there are certain diagrams in OCT. One is ENFAS. So ENFAS is nothing but 2D representation of the 3D volumetric data. And the depth of the retina where this ENFAS is taken is known as segment. If the patient moves his eyes, you can have these motion artifacts as you see in this image. Then you have projection artifacts, flow, void, and various indices. Then there are other quantifiable variables in OCT angiography like foveal avascular zone. It is the size of the fovea, the avascular zone of the fovea. Acircularity index. It is how acircular your fovea is from a perfect circle. Vessel density. FD300 is vessel density around 300 micron region around foveal avascular zone. Perfusion density and extrafoveal avascular area is an avascular area outside the 1 mm diameter circle center over the fovea. So why do we need to know this? Because these quantifiable variables can act as a sensitive biomarkers. As FD300 can detect diabetic retinopathy before the clinical DR happens, extrafoveal avascular area in the superficial capillary plexus can discriminate non-diabetic retinopathy from an NPDRIs, while vessel density in deep capillary plexus can distinguish NPDR from the PDR. So in our study, in our pioneering study as well as study from Belly et al., we can clearly delineate between a neovascularization as well as collaterals by just looking at two things. One, the morphology of the vessels. Second, the flow. If you see flow in the vitreous with an abnormal vessels present, you're probably looking at a neovascularization. OCT angiography can not only detect choroidal neovascular membrane, it can tell you which is the type of the neovascular membrane it is. It is type 1, type 2, type 3. And if you see this abnormal vasculature in the superficial, intermediate, and deep capillary plexus with the flow, it is probably a type 3 or a McTell. Oh, sorry, type 3 or an RAP lesion. So manual segmentation is very important. Look at the image on the right. If you see an abnormal segmentation, make you feel that this is an CNVM, but then if you correct the segmentation, it is gone. Always correlate the ENFAS image with the structural image. Look at the central circle. You think it's a CNP area, but it's not a CNP area. It is rather a cystic spaces that is visualized as a CNP area or a flovoid area in OCT angio. So always correlate the ENFAS with the structural OCT. OCT can also detect the flow void area in the middle or the deeper capillary plexus, allowing us to understand and visualize pathology which were affecting only some certain layer of retina, like paracentral acute middle maculopathy or sickle cell maculopathy, which affected middle or deeper layer of retina. With OCT angiography can also help you to identify NV in RVOs. You can also assess the assessment. You can also assess these patients how well they are doing on the treatment, because reduction in the size of this neovascular complex with decrease in the flow in the over there can help you understand that your treatment has taken a good effect. Not just that, OCT angiography works well in uveitis, because if you see these flow void areas, choroidal granuloma in VKH. So when these flow void areas are gone in the choriocapillaries plane, this means this is the time when you can stop immunosuppression or steroid in this patient. So it guides you the treatment. At the same time, in certain identities like multiple events on white dot syndrome, where you have choriocapillaritis, because choriocapillaries are so small, and the problem with the OCT angiography, it does not detect flow in the smaller vessel, can help you to differentiate the other white dot syndrome. So with the DREAM OCT coming up now and ultra wild field OCT, you can even tap into the diseases which was only limited to ultraviolet field angiography that is like IRWAN. So we literally see an IRWAN disease with OCT angiography. In this, I always quote this article by Brazilian et al. So SWEPSOS OCT, look at this OCT. This is an FFA and an OCT. FFA you don't see, you just see a blocked fluorescence. But you do an SWEPSOS OCT in this patient, you see that macroaneurysm. So now the hemorrhage with macroaneurysm, you know the reason of macroaneurysm with the help of SWEPSOS OCT angiography. So that's not it, because with the help of OCT or NGO, you can detect CNV chronic CAC, you can identify MACTEL, it can help you to help as a pre-perimetric test in glaucoma, as well as in various hereditary and retinal disorders. So how and why? So always remember that you should know the anatomy, because until unless you know it, you cannot identify it. Second is always adjust the segmentation manually. Look for abnormal in the normal. Correlate the structural OCT with the and fast OCT. Look for the flow as well. Apply the right scanning protocol to clinch the diagnosis. For example, if you're looking at an foveal region like in AMD, use the 3 by 3 mm protocol. When you're looking at an outer retinal disease or a disease which affects the periphery, use a wider frame. Scanning part is easy, interpretation is at its infancy. Just practice, practice to learn. Thank you.
Thank you for that enlightening and insightful talk, sir.